Hello citizens of Internet. I am Professor Ajit Virkud from Mumbai, India. Today I am going to take a masterclass on Diabetes Mellitus, especially management of type 2 diabetes. This is part 1 where I will be discussing basics of the disease, without which you will not be able to understand part 2, in which I will talk about management of diabetes mellitus using oral hypoglycemic agents. The entire talk is based on the guidelines given by American Diabetes Association, which were published in the year 2022 but were applicable from the year 2023. I will try to make it as practically useful as possible. Please see this part 1 before watching part 2, which is about management of type 2 diabetes using oral hypoglycemic agents. Subsequently, in the masterclass, I will talk about use of insulin in the management of diabetes mellitus and also about management of gestational diabetes mellitus. One more very important thing. This presentation is meant for qualified medical personnel only. All the drugs I am going to discuss must be prescribed by qualified doctors and should be taken only under medical supervision. This is a graphical representation of how diabetes mellitus occurs. In simple terms, in type 1 diabetes, the pancreas fails to produce sufficient insulin to maintain blood sugar levels. When the cells of the body fail to respond to circulating insulin, it leads to type 2 diabetes mellitus. In 2019, it was estimated that 7.7 crore people had type 2 diabetes mellitus in India, which might rise to 13.4 crores by the year 2045. From the gynecologist's point of view, gestational diabetes mellitus and PCOS are two important predisposing factors for developing type 2 diabetes mellitus later in life. According to ADA, type 1 diabetes occurs due to autoimmune beta cell destruction, usually leading to absolute insulin deficiency. It also includes latent autoimmune diabetes of adulthood. Type 1A and type 1B have been removed in the ADA new classification. In ADA classification, there is no mention of hybrid forms which are mentioned in WHO classification, such as latent autoimmune diabetes of adults, which is now included in type 1. By definition, type 2 diabetes mellitus is due to a non-autoimmune progressive loss of adequate beta cell insulin secretion, frequently on the background of insulin resistance and metabolic syndrome. Class 3 refers to specific types of diabetes due to other causes, for example, monogenic diabetes syndrome, such as neonatal diabetes and maturity onset diabetes of the young. Diseases of the exocrine pancreas, such as cystic fibrosis and pancreatitis, and drug or chemical induced diabetes, such as with glucocorticoid use in the treatment of HIV/AIDS or after organ transplantation. Class 4 is gestational diabetes mellitus, that is, diabetes diagnosed in the second or third trimester of pregnancy that was not clearly overt diabetes prior to gestation. I have made a separate video on gestational diabetes mellitus, especially its pathophysiology. Please watch it. The link is given below. Now I will come to diagnosis of diabetes mellitus. ADA has given following 4 criteria for exact diagnosis of diabetes mellitus. Any one criteria will do. First, fasting plasma glucose greater than 126 milligrams per deciliter, that is 7 millimoles per liter. Fasting is defined as no caloric intake for at least 8 hours. Or second criteria, 2-hour plasma glucose greater than 200 milligrams per deciliter, that is 11.1 millimoles per liter during OGTT. The test should be performed as described by WHO using a glucose load containing the equivalent of 75 grams of anhydrous glucose dissolved in water. Or, third criteria, hemoglobin A1C greater than 6.5%, that is 48 millimoles per mole. The test should be performed in a laboratory using a method that is NGSP certified and standardized to the DCCT assay. Or, fourth criteria, in a patient with classic symptoms of hyperglycemia or hyperglycemic crisis, a random plasma glucose greater than or equal to 200 milligrams per deciliter, that is 11.1 millimoles per liter, is diagnostic of diabetes mellitus. I have colored hemoglobin A1C differently in my slide because that is the criteria which most diabetic specialists use for diagnosis of diabetes mellitus. Also remember that in the absence of unequivocal hyperglycemia, the diagnosis requires two abnormal test results from the same sample or in two separate test samples. Now let me talk about the symptoms of diabetes. In the past, classic symptoms of hyperglycemia were considered to be polyuria, polydipsia, and polyphagia. However, now according to ADA, polyphagia is no longer considered a classic symptom. Instead, weight loss is included as an important classic symptom of type 2 diabetes mellitus. High-risk population comprises first-degree relatives with diabetes, high-risk race ethnicity, for example, Southeast Asians, African American, Latino, Native American, American, and Pacific Islanders. History of cardiovascular disease, hypertension that is greater than 140 by 90 millimeters of mercury or on therapy for hypertension. HDL cholesterol level less than 35 milligrams per deciliter and a triglyceride level greater than 250 milligrams per deciliter. Individuals with polycystic ovarian syndrome, physical inactivity. Other clinical conditions associated with insulin resistance, for example, severe obesity, acanthosis nigrans, etc. These patients should be screened for diabetes mellitus. The question is, when and how often should they be screened? Pre-diabetics should be screened every 1 year. Women who had GDM in their previous pregnancies every 3 years throughout their life, because there is a 50% risk of contracting type 2 diabetes mellitus in these women. In the general population with no risk factors, one must start screening after the age of 35 years. In the past, it was 45 years, but ADA has now changed it to 35 years. It goes without saying that in the high risk population and pre-diabetics and women with GDM in previous pregnancies, one can start screening a few years earlier. Now let me clear a few concepts regarding diabetes mellitus about which there is a lot of confusion in the minds of physicians and public at large. What is reversal, remission, and cure for diabetes mellitus? Reversal refers to simple return to normoglycemia with treatment. On the other hand, when normoglycemia, that is hemoglobin A1C less than 6.5%, is maintained for at least 3 months in the absence of glucose lowering drugs, it is called remission. Although the terms reversal and remission are used interchangeably, recent consensus supports the use of the word remission in the context of type 2 diabetes mellitus. It should be noted that bariatric surgery can reverse type 2 diabetes mellitus and change outcomes for obese patients with type 2 diabetes mellitus. Lastly, it is important to note that the term cure has not been applied to type 2 diabetes mellitus. What it means is that as yet there is no cure for type 2 diabetes mellitus. Now let me say a few things about prevention of diabetes mellitus. Yes, it is possible to prevent overt diabetes mellitus in pre-diabetic individuals. Pharmacotherapy, that is use of anti-diabetic agents, is recommended for pre-diabetic patients. However, it is not recommended for general population and individuals without any high risk factors. Criteria for labeling a person as pre-diabetic are age 25 to 59 years with BMI of greater than 35 kilograms per meter square. The age can be modified to 30 for Indians and having fasting plasma glucose greater than 110 milligrams per deciliter and or hemoglobin A1C greater than 6% and previous history of gestational diabetes mellitus. Drugs like metformin and pioglitazone have been recommended in these individuals. Lifestyle modification has also been suggested for prevention. Physical activity for at least 150 minutes per week, resulting in at least 7% weight loss, has been shown to be beneficial. This brings about statistical reduction in conversion rate. Studies have shown that lifestyle modification is more efficacious than metformin for prevention of diabetes mellitus. Please note that pioglitazone does not truly prevent type 2 diabetes like metformin does, but it only lowers the risk of stroke and myocardial infarction and progression to diabetes mellitus. Thus, it only reduces the microvascular events associated with diabetes. It should be noted that these complications can occur even in the pre diabetic stage, hence, the role of pioglitazone. Long-standing untreated diabetes mellitus is associated with many chronic complications. Chief among them are diabetic nephropathy, diabetic retinopathy, diabetic neuropathy, cardiovascular disease, and stroke. There are many others, but I cannot list all of them. Remember, diabetes affects all major organs in the body. Also note that diabetes per se does not kill the patient. It is the major complications mentioned here which are responsible for the mortality associated with diabetes mellitus. The traditional comorbidities associated with diabetes mellitus are hypertension, dyslipidemia, and non alcoholic fatty liver disease NAFLD. But one must remember that there are other equally important comorbidities such as cognitive impairment, periodontal disease, hearing loss, fractures, hypogonadism, especially in males, and PCOS in females. Don't overlook these comorbidities. Of these, I consider periodontal disease as quite important because not only is it neglected, but also it can increase the risk of atherosclerosis, cardiovascular disease, and hamper with glycemic control. In patients diagnosed with diabetes mellitus, investigations must be done to look for these comorbidities. And now I will come to what is the most important part of management from the practical point of view. Managing physicians must know what are the glycemic targets to be achieved after treatment is started. Traditionally, we use three metrics: fasting plasma glucose in the range of 80 to 130 milligrams per deciliter, postprandial plasma glucose of less than 180 milligrams per deciliter, and hemoglobin A1C less than 7%. For type 2 diabetes mellitus with hypoglycemia, ADA has relaxed the hemoglobin A1C target to 7.5%, and for elderly frail individuals, they have relaxed it further to less than 8%. Besides the traditional targets, ADA has now added one more metric of time in range that stands for assessing glycemic variability. It is identified from continuous glucose monitoring. It is calculated as for what percentage of time in a day is the plasma glucose level within a target range. For an average type 1 or type 2 diabetic patient, the target range should be present 70% of the time. This timing range differs slightly for different types of patients. For example, in old, frail patients, the target time range can be present only in 50% of time, as shown in the middle graph. For pregnant women with GDM or PGDM, the target range of 63 to 140 milligrams per deciliter should be maintained for 90% of the time. That is, in GDM patients, tight glycemic control almost throughout the day is very important. Just to reiterate what I said, the target glycemic range for pregnant and non pregnant patients is as follows. For non pregnant male and female patients, the target range is defined as 70 to 180 milligrams per cent, but for pregnant women where tight glycemic control is necessary, the target range is 63 to 140 milligrams per cent. With advances in technology, it is now possible to calculate this target range using continuous glucose monitoring devices, also known as CGM devices, which is shown here. With the basics done, let me do a brief overview of management of type 2 diabetes mellitus. It is not just glycemic control using oral hypoglycemic agents and or insulin. There are other important pillars of management as shown here. These are blood pressure management, management of dyslipidemia, and using oral hypoglycemic agents that benefit cardiovascular and kidney health. At the same time, important role of education and counseling of the patient and lifestyle modification should never be underestimated. Reduction of complications of diabetes mellitus is extremely important as they are the ones that kill the patient. Diabetes per se is not lethal. Comprehensive management is the key to tackling diabetes mellitus. Since I am talking about ADA 2022 guidelines, let me mention the exercise protocol for diabetes mellitus according to ADA. These are: patients should engage in 150 minutes or more of moderate to vigorous intensity activity weekly, spread over at least 3 days per week. There should be no more than 2 consecutive days without activity. Resistance training in 2 to 3 sessions per week on non consecutive days. Flexibility training and balance training are recommended 2 to 3 times per week for older adults with type 1 diabetes mellitus according to ISPAD 2018 guidelines. Patients should do 60 minutes or more of physical activity each day, which should be moderate to vigorous aerobic activity. It should also include muscle strengthening and bone strengthening activities. Although this is not part of ADA guidelines, I feel what they say means that in the initial stages, the patient should do these training exercises under supervision of a certified gym trainer. Before I talk about various oral hypoglycemic agents, let me mention situations where giving insulin is a must. These are: in pregnant patients with PGDM or GDM, American Diabetes Association recommends giving only human insulin. However, in practice, many physicians do give oral hypoglycemic agents like glyburide. To learn more about this, please see my video on GDM. The link will be given below. Other situations where insulin is default treatment are hemoglobin A1C greater than 10%, random plasma glucose greater than 300 milligrams per deciliter, patient having features of catabolism, that is significant weight loss, and ongoing ketosis. Some Indian guidelines have mentioned a few more indications such as hemoglobin A1C greater than 9% with 3 or more oral hypoglycemic agents, severe organ involvement, for example, liver or kidney failure, and perioperative patients where we usually give insulins. Before I end, since we have time, I will briefly mention the oral anti-diabetic drugs that are used in the management of diabetes mellitus. This will help me talk more in depth about management of type 2 diabetes mellitus using these oral agents in part 2 of my masterclass on diabetes. I call them oral hypoglycemic agents, OHA in short, or anti-diabetic agents, ADA in short, interchangeably. There are 6 classes of OHAs. I will enumerate the practically important ones here. To understand the next part of my masterclass, this slide is of paramount importance. So pay close attention. First, metformin. ADA recognizes metformin as the first line or primary hypoglycemic agent that should be used in all cases once the diagnosis is made. It is a class 1 agent called biguanides. Biguanides are agents that lower glucose levels by their actions on the liver, muscle, and adipose tissue. Metformin is available as 500, 850, or 1000 milligram oral tablets. Some sustained release preparations are also available. The maximum dose of metformin is 850 milligrams 3 times a day. Secondary anti-diabetic drugs that are added to metformin are DPP-4 inhibitors such as vildagliptin and sitagliptin, second generation sulfonylureas like glimepiride and glyburide, SGL2 inhibitors like dapagliflozin, GLP-1 receptor agonists like liraglutide and semaglutide, and alpha glucosidase inhibitors such as acarbose and voglibose. Please note, this is not an exhaustive list. Talking in details about the pharmacology of these drugs is beyond the scope of this lecture. Practically, it is very important to know which drugs are efficient in reducing weight and which others are not. This is because many diabetes mellitus patients, especially in the Western world, are very obese and they are more concerned with their excess weight than with their excess glucose. Semaglutide and tirzepatide, which are combined agonists of GLP-1 and GLP, have a very high efficacy for bringing about weight loss, which is preferred. Dulaglutide and liraglutide have a high efficacy, whereas GLP-1 receptor agonists and SGL2 inhibitors have intermediate role in reducing weight. Metformin and DPP-4 inhibitors have low or neutral efficacy as far as weight loss is concerned. If you want to know more about this topic or any other topic in obstetrics and gynecology, please refer to my books Modern Gynecology, Modern Obstetrics, and Practical Obstetrics and Gynecology, and other books. For purchase inquiries, contact me on this WhatsApp number. I have also published 2 question answer books which are particularly useful for exam going students. These are Clinical Cases in Obstetrics, 1000 plus questions and answers, and Clinical Cases in Gynecology, 1000 plus questions and answers. You can also follow me on other social media platforms like Facebook or Meta, Blogspot, and Instagram. The links are given here. If you enjoyed this video, hit the like button, share it with your friends, and also subscribe to my channel for more videos like this. Thank you for watching.